glaucoma management and beyond. This is a faculty talk session. The first talk will be Approach to Glaucoma Suspect Identification and Management by Dr. Pranamita Pujari. Please, ma'am.
प्रणमिता पुजारी यहाँ पे नहीं दिखेगा। हाँ वहाँ पे क्या था? क्यों नहीं हुआ? कितने पहले ही कर चुके हैं। कुछ हो गया ना अच्छे से पहले। हाँ So I am Dr. Pranamita Pujari and I am going to speak on how to approach a glaucoma suspect. If you see this case, a 44-year male patient who came for second opinion. He was on combination of brimonidine timolol eye drop for a baseline IOP of 27 by NCT with a normal visual field and OCT report. When I saw the patient was non-diabetic, non-hypertensive, family history was negative, and when I did explanation, the IOP came out to be 24 millimeter. Optic disc, RNFL, everything was normal, and angle were open on gonioscopy. And when I did PACI, it's not running. When I did PACI, I got 590 micron. So we should think whether the patient needs treatment or the patient needs follow-up. It is seen that 15 to 50% of glaucoma patients on anti-glaucoma medication, they do not meet the criteria of glaucoma. And at the same time, 50 to 90% of cases, glaucoma is undiagnosed. So it is essential to eliminate both under and overdiagnosis by identifying the glaucoma suspect correctly. Glaucoma suspect is a patient who has clinical findings and are all constellation of risk factors that indicate an increased likelihood of developing glaucoma, but you cannot label the patient as glaucoma. And it is seen that 25 to 30% of the patients attending the glaucoma clinic are actually glaucoma suspect patients. They can be open angle glaucoma suspect or angle closure suspect. Open angle can be optic disc suspect or visual field suspect or the IOP suspect or the ocular hypertension group. So vertical curve ratio more than 0.7, that patient always is not a glaucoma because 5% of normal population can have vertical curve ratio more than 0.7. And the rule which we insist isn't rule, that is followed in 70% of eyes, and that applies only to the normal size disc. If you see this is a large disc and large curve, that is also normal, and the other disc is also normal. Visual field suspect, if you see, we see some depressed point on the visual field and we start treatment, but any visual field defect appearing suddenly, it's not a glaucomatous visual field. I will discuss this later. Ocular hypertension group, we know they have open angle, their optic disc and visual field are normal, and we should see that there is no secondary cause of rise of IOP. Now, two landmark trials, ocular hypertension treatment study and the European glaucoma prevention study, they define the risk factor where a patient is at more risk for developing glaucoma. So they are the higher IOP, older age, family history, thinner central cornea, large curve disc ratio, and higher pattern standard deviation on visual field. And these are the additional risk factor also, and they develop by combining the longitudinal data of the OHTS and EGPS. This risk calculator is also developed. It's available online, but not many people use this. I also don't use it, but it's available there. Now, how will you approach a glaucoma suspect? Like we see, intraocular pressure is a major risk factor, and remember that Goldman applying tonometry is the gold standard to diagnose IOP and label the patient as glaucoma. Single IOP reading is not reliable. We have to determine the full extent of IOP fluctuation over time. And diurnal IOP should be done in all glaucoma suspects, especially in optic disc suspect patient and NTG scenario patient. Ideal will be 24-hour diurnal IOP, but if it is not possible, then one should go for a office IOP 8 a.m. to 6 p.m. Now, thinner cystry is another important risk factor for progression to glaucoma, and pachymetry is must for all patients at baseline. And if you do pachymetry, you will see that the ocular hypertensive patient is actually a normotensive patient, and the NTG patient is actually a open-angle glaucoma patient. Now, optic nerve head should be evaluated thoroughly. An ideal will be a stereoscopic view with a 90° or 78° lens, and documentation is must. One should go for stereophotography, or if it's not available, at least document with a disc photo. And not only just see the vertical curve disc ratio, but thoroughly evaluate the optic nerve. Imaging technique is important for baseline and follow-up, and progressive analysis program help to detect the optic nerve and RLFN changes. But OCT is important for follow-up in glaucoma suspect, not for initial diagnosis or initiation of treatment. And results must be interpreted in conjunction with the other risk factor and clinical examination and visual field. Now, visual field, one should try to get at least 3 visual field during the first year of assessment. And remember that the hallmark of a glaucomatous field is progressive visual loss, which cannot attribute to any neurological defect. And if there is suspicious visual field on consecutive test, then one should try to exclude the neurological and medical condition causing the visual field defect, like optic disc abnormality, retinal abnormality, and CNS abnormality. Coming to the management part, it was seen in ocular hypertension treatment study that 90 to 95% of the patient didn't develop glaucoma over 5 years. And the NNT number needed to treat is for every 20 cases treated for 5 years, we can prevent only 1 progression. So individual risk assessment is important. But the patient should be followed properly, serial evaluation should be done, and patients should be educated regarding the risk factor, prognosis, and importance of the follow-up. IP should be checked every 2 months, field test every 4 months, and if there is no change, then every 6 months, and if still there is no change, you can go for yearly field test. ONS documentation is also important, and if stable, then every 6 months to annual, you can see for the progression. Now, when you will start treatment in a glaucoma suspect patient, suppose the patient gets converted to POAG patient, or there is a new appearance of the visual field defect which is confirmed on retesting, and there is consistent IOP or risk factors are there. Now, IP reduction aim is to decrease by 20%. Treatment option can be eye drop and SLT also. Last entity, angle closure suspect, we all know their occludable angle is there more than 180°, and all PSCS patients don't need treatment, but they should be counseled regarding the risk of developing an acute attack. In cases where you go for laser iridotomy, like one patient, fellow eye has PAC, PACG or AAC, patient having symptoms of prior angle closure. And lastly, I will say, if the patient is ready to go for iridotomy, after understanding the risks, then also you should take the patient for laser iridotomy. Thank you, everyone. So to conclude, I will say, it's a diverse group, and it's a life-changing condition to label a patient as glaucoma. So one should exercise caution before labeling a patient as a glaucoma suspect patient.
Thank you very much. Can we have the next speaker, Dr. Indu Pandey, on angle closure glaucoma? Now, it's a jam-packed session of 10 speakers, and so they will take the questions at the end, or you can give us in a slip of paper, and we can take the questions at an end. Thank you.
This is someone else's.
We have on both sides audio video so that the other person can be ready. We can reduce the changeover.
This is someone else's which has got opened.
आप 2 जगह लगा सकते हो.
Could you help, please? किसी और का खुल गया. इंदु पांडे.
Do you have 2 laptops? Yes or no? You have? Then put one here, please.
Good afternoon to all the dignitaries in the dais and all the people which are present in the audience. I shall be presenting my talk on angle closure glaucoma and discussing the management of acute angle closure crisis. This quote has been taken from an ancient Chinese text, which means if there is free flow, there is no pain, and if there is pain, there is lack of free flow. And this holds so very true for our glaucomas. Angle closure is defined by the presence of iridotrabecular contact, which may be synachial or appositional, primary or secondary. Ethnic background is one of the key factors in determining susceptibility to primary angle closure. It is more common in people of Asian descent, and the other demographic factors are female gender, older age, and the presence of a first-degree relative in the family. And then the anatomical factors are hyperopia, thickened lens, short axial lens, shallow anterior chamber. The other precipitating factors can be emotional stress, dim illumination, mydriasis, intense meiosis, and use of certain drugs. Then the predominant mechanism, which is found in about 75% of the cases, is a pupillary block mechanism, in which the flow of aqueous is impeded from the posterior chamber through the pupil to the anterior chamber, and the pressure in the posterior chamber becomes higher than that in the anterior chamber, and iris bows forward to lie over the trabecular meshwork. Then there can be anomalies at the level of the lens also. There are changes in the shape or increased size of the crystalline lens with advancing age in predisposed eyes with smaller anterior segment. Like this patient who presented to us with acute angle closure crisis, and after lowering the intraocular pressure, when we did the anterior segmentosity for this patient, we found the lens vault in right eye was 1,225 microns, and in the left eye it was 1,027 microns. So for this patient, we did a clear lens extraction with PCIL implantation, and the patient is now doing very well without medications and having open angles. There can be anomalies at the level of iris or ciliary body also. These are the result of variations in the iris and ciliary body anatomy, which include a thicker iris, a more anterior iris insertion, and a more anterior ciliary body position. Then there can be anomalies which may be posterior to the lens, which may occur following trabeculectomy, lens extraction, laser iridotomy, and other surgical procedures. There's a classification system which has been proposed by the international glaucoma specialists, which includes the three terminologies, that is PACS, PAC, and PACG. PACS is 3 or more quadrants of ITC, normal intraocular pressure, no PAS, and no evidence of GON. And PAC is iridotrabecular contact, resulting in raised intraocular pressure and or peripheral anterior synechia. And PACG includes all these, but with glaucomatous optic neuropathy. So what we find over here is that the most crucial thing is a darkroom dynamic gonioscopy, and that should be the standard of examination. These patients normally present with acute, intermittent, or chronic, and now I shall be talking about acute angle closure crisis, in which the patients usually present with eye pain, headache, blurred vision, colored halos around light, nausea and vomiting, injection of the cornea and injection of the conjunctiva, cloudy cornea, mid-dilated pupil fixed, very high IOP in the range of 50 to 60, and iris bombay. The sequelae may be in the form of sectoral iris atrophy, glaucom flecken, peripheral anterior synecdoche, pigment deposition of the iris and cornea, disc hyperemia, disc pallor, and cupping. These are the sequelae which we can see in the form of iris spiraling and several patches of optic atrophy, iris atrophy. So coming down to the management of acute angle closure crisis, which rests on 3 tenets, that is decreased aqueous humor production, reopening the angle, and reducing the inflammation. For decreasing aqueous humor production, we can do topical therapy in the form of beta blockers or alpha-2 agonists, and systemic therapy like IV or oral acetazolamide or hyperosmotic agents. For reopening the angle, we can use pilocarpine 2% pharmacologically, and mechanically it can be done by corneal indentation with a 4-mirror gonio lens or simple thumb pressure, or we can also consider clear corneal paracentesis, and then topical steroids can be used for reducing the inflammation. After the pressure has come down to lower 30s or higher 20s, then we can think of doing iris procedures in the form of iridotomy, iridectomy, or iridoplasty. And also remember prophylactic iridotomy in the other eye. Prophylactic laser iridotomy can be done in the cases of elevated IOP with appositional closure, greater than or equal to 22 and 70 degrees of apposition, narrow angle with PAS, history of AACG in the fellow eye, and iridotomy in the fellow eye. Now, a word about EAGLE study. There is evidence that clear lens extraction may be superior to iridotomy, especially in Asian populations. Randomized comparison of iridotomy versus clear lens extraction in patients with primary angle closure and primary angle closure glaucoma was done. There were 419 patients at 30 centers in 5 countries. And those who were assigned to phacoemulsification, they had better quality of life indices, lower intraocular pressure, and far fewer medications. So it has been seen that clear lens extraction showed greater efficacy and was far more cost-effective than laser peripheral iridotomy and should be considered as an option for first-line treatment. So the take-home points are gonioscopy is indispensable, and this technique should be learned and mastered and be done as a part of routine eye exam. ASOCT measurements and UBM, like angles, angle lens vault, and ACD, offer newer methods to evaluate and treat glaucoma. Prophylactic laser iridotomy to be done in all PACS cases, and EAGLE study offers compelling evidence in favor of clear lens extraction and can be considered as a first-line treatment for maintenance of quality of life parameters in PACG cases. However, each case has to be done on its individual merit. Thank you.
The next speaker is by Dr. Smriti Jain, and the topic is start early, lower, fewer, and better.
I'm Dr. Smriti Jain. Welcome everybody. And this is something that I want to discuss, that all therapies, whenever we have glaucoma, let us start early, let us lower the pressure with fewer drugs for a better control and a better patient experience. It's not going.
Excuse me,
Yeah, so glaucoma is the second leading cause of blindness in both developing and the developed countries. The risk factors for blindness are a higher IOP, worse visual field status at presentation, and an older age group. The goals of glaucoma treatment, we all know, is to maintain patients' visual function at a sustainable cost. Visual field loss definitely decreases the quality of life and causes a lot of problems in patients as the glaucoma advances. Now, if we look at this chart, the normal visual decay and the clinical glaucoma, which is controlled, the decay, the mean rate of progression is almost similar. So if we treat a glaucoma well, then we actually prevent the decline in the vision. So as presented earlier, ocular hypertension, we all know, where the pressure is really high, but there are no other field changes or optic nerve changes. Now, we have to remember, if the pressure is above 30, we need to treat these cases. We always have that risk calculator. We calculate the risk and, of course, put them on treatment. If we have a lower CCT, higher cup disc ratio, so we just follow this and treat them early. Normal tension glaucoma is another one where the pressures are not high and we can miss the glaucoma. So the crux lies in careful examination of the optic nerve and a high suspicion rate. Do fields, the visual field defects will be closer to fixation, and these are the cases where patient can have a, progression very fast. So what really to focus on in NTG is, anemias, arrhythmias, other things, the sleep apnea, treat those as well. A dip in the nocturnal blood pressure also needs to be controlled. Important signs to look for is the disc bleeders, and we need to get the pressures down by at least 30% in these cases. Now the rate of visual field progression can vary between different patients, and that is how we should start the therapy and upgrade the treatment. So A is the normal person with a normal visual decline. B is a patient who has presented late. I mean, his age is more and there is a decline, but it is moderate. So we can control adequately with maybe a single drug. C is the patient with a similar kind of a visual field, but we have picked it up early. The patient is younger. we need to be more aggressive here so that the visual field does not deteriorate. And we need to be continuously monitoring. At least 6 visual fields in the first 2 years will give us the rate of progression. Chart shows us that there is a fast visual deterioration here. So here we need to be very aggressive, maybe go in for a surgery or medication. So earlier and lower, what I mean by this is that detection of an early visual field progression may help us to prevent the further loss. We can step up the treatment. Now, something very important is that we have to keep in mind whenever we are treating the patients is the target IOP. Now, what is a target IOP is just a range where we feel that the progression will not happen. Supposing we encounter a patient who has a pressure in 30s. So let's start with at least a 35% reduction in that and then go forward. We have to keep assessing these patients regularly and keep adjusting the target pressure accordingly. If there is progression on repeat examinations, then we decrease the target pressure further. So a staggered percentage reduction system like 30, 40 or 50% can be recommended for mild, moderate and severe glaucoma. So the target pressure depends on how much is the pressure, what are the additional risk factors, more importantly the rate of progression. This is a chart where we can approximately, we know as we have advanced glaucomas, the target pressure goes down and further down. So the initial treatment usually is medical treatment what we start, and prostaglandin analogs are usually preferred as the first choice because of high systemic safety, highest reduction in pressure, a good 24 hours control and 1 drop a day of a prescription. We have too many medications these days. We have a battery of medical therapy. We also have fixed dose combinations. So we always need to start with a single drug in most cases. If you really feel the pressures are high, then you can go for a fixed dose combination initially. Now the meta-analysis of medical treatment also shows bimatoprost is the winner here. It has a marginal benefit as compared to latanoprost and travoprost. Bimatoprost 0.03% used to show us a lot of hyperemia and ocular surface disorders, but with the bimatoprost 0.01%, these things are better controlled. It is almost comparable with latanoprost. Now early progression within the target IOP, even if you have set the target IOP, if there is progression, get the pressure down again. So in that case, either you can switch the drug. Supposing the patient is on prostaglandin analog, you can switch the treatment and see between the prostaglandin analog, the latanoprost to travoprost or to bimatoprost, before you step up therapy and add another drug. Bimatoprost plus timolol is a fixed dose combination, and both these drugs are synergistic in action and achieve a good control of IOP. By mixing these two drugs, also the adverse effects have found to be decreased. The hyperemia comes down, the burning sensations are less, foreign body, whatever we have encountered more with bimatoprost. Somehow after adding the timolol, the patient is more tolerant to this drug. Bimatoprost and timolol again have a small advantage, again latanoprost timolol combination as well as the travoprost timolol combination. Why efficacy after switching? Most frequent reasons for switching to bimatoprost timolol fixed dose combinations were insufficient IOP lowering on prior therapy, progression of glaucoma related damage, unacceptable tolerability of prior therapy and lack of compliance. With a single dosing, usually patients are better compliant, there will be less side effects, and it has a lot of advantage. The conclusion for today is, once a patient is diagnosed of glaucoma, characterizing a risk profile is useful to plan and individualize the treatment strategy. Main factors are the visual field damage and IOP. Target pressure needs to be set. Patients shows a meaningful risk profile may benefit from an earlier and lower IOP reduction with medical treatment. Highest efficacy is achieved with prostaglandin analogs. Along them, bimatoprost is the most efficacious one while preserving a good tolerability profile. At follow-up, Early and fast progressors deserve additional, earlier and stronger intervention with fewer and better treatments. These patients may benefit from a fixed dose combination, and that's about it. Thank you.
Next speaker, approach to the primary angle closure disease, Mithun Tulsi Das.
Respected Chair and delegates, good afternoon. So as Dr. Intu ma'am has already spoken about the disease, I'll be actually giving a case-based presentation followed by a brief discussion. So I'll be talking about approach to primary angle closure disease. So case 1 is a 60-year-old woman who presented to us with blurring of vision in right eye since 6 months. She had previous episodes of recurrent redness and pain over 2 years. And in right eye, the corrected distance visual acuity was 6/18 with an IOP of 28. Left eye was 6/6 with an IOP of 18. Now, as you can see in the anterior segment picture, right eye, the anterior chamber is shallow with loss of pupillary rough and iris atrophic patches and a subcapsular opacity suggestive of glaucoma flecken, which was correlating with the history with previous episodes of acute angle closure attack. On the other hand, the left eye, the anterior chamber was shallow, rest of the examination was within normal limits. When you do a gonioscopy, you can see occludable ankles in both the eyes with 180-degree peripheral anterior synechia in the right eye. And when you see the fundus picture, right eye shows a disc with inferior neuroretinal rim thinning and a cup disc ratio of around 0.6 to 0.7, whereas the left eye picture was within normal limits with around 0.3 cupping and healthy neuroretinal rim. When I did a visual fields, again it was correlating with the clinical picture. The right eye showed a superior arcuate scotoma and a nasal stub inferior extending to the arcuate area with a mean deviation of -16 decibels suggestive of advanced glaucoma, and left eye was normal. Diagnosis was clear. It was right eye primary angle closure glaucoma with immature cataract and left eye PACS. So the treatment, I've done a phaco trap with MMC in the right eye as the patient already had an advanced glaucoma with cataract, and left eye we need to definitely do a laser peripheral iodotomy considering the fellow eye status. Case 2 is about a 58-year-old woman who came with headache and eye pain since 3 months episodes associated with nausea sometimes. She was a hypermetrop. Diopy was 24 in right eye and 23 in left eye. Anterior segment examination revealed a grade 1 Van Herrick's and a clear lens. Fundus examination was within normal limits. Again, on gonioscopy, you can see occludable ankles in both eye, which on indentation opened up. So the diagnosis was both eye primary ankle closure because here we have an iridotrabecular contact of more than 180 degrees with a raised intraocular pressure. Again, the treatment plan is nothing less than a laser peripheral iodotomy. Case 3 is 66-year-old woman who came with blurring of vision in both eyes in 3 months. Now she had a few episodes of headache and also diabetic over 5 years. Visual acuity was 6/9. She was also a hypermetrop and the intraocular pressure was 21. Anterior segment examination revealed a grade 2 Van Herrick's and also a significant cataract which is around nucleus sclerosis 2. Fundus examination was within normal limits. Now this is one situation which most of us face in our clinical practice, like you will have both cataract with a suddenly slightly borderline IOP, and yes, obviously when you do a gonioscopy it will be occludable and on indentation it might open up. So in such cases you will be little doubtful whether to dilate the patient initially or whether to go for an iridotomy first, but in my practice, what I usually do is if there are no significant clinical findings in the optic nerve head and when the intraocular pressure is high but no peripheral anterior synechia on gonioscopy, then you can definitely give it a try by dilating and check the IOP after dilatation also. Now you can see the IOP didn't increase much after dilatation. It was almost in the similar range and the cataract was significant. Such cases, you can directly go ahead with phacoemulsification. There is no need of biotreatment with any laser procedure. So a both eye phacoemulsification will give a very good outcome with good visual acuity and a controlled intraocular pressure after the surgery. Now, what is the importance of primary angle closure disease? So as per 2020 global estimates, the ratio of PACG to POAG is in the ratio of 1:3. but the ratio of blindness is 1:1, which means the risk of severe bilateral visual impairment is more with angle closure disease. Now the risk factors have already been explained by Dr. Intu ma'am. So shallow anterior chamber, short axial length, thick irisol lens, emotional stress, nervous individuals, Valsalva, dim light, all these are risk factors. Now there are basically three mechanisms. One is the pupillary block, which conventionally we know. Second is the lens related. So it is always preferable to check the size of the lens in cases with significant cataract, because sometimes a high lens vault can also predispose to ankle closure. Third one is the plateau iris, like you can see a double hump sign, which is classical on gonioscopy. One hump is due to the anteriorly positioned ciliary body, and the second one by the equator of the lens. Now, as per International Society of Geographical and Epidemiological Ophthalmology, we have usually 3 subtypes, which we usually follow in clinical practice. So an ITC, that is iridotrabecular contact of 180 degree with normal features. Other than that, it is suspect. With an elevated IOP or evidence of PAS, it is angle closure. With optic disc changes, then it is angle closure glaucoma. Diagnosis, definitely when now gonioscopy is the gold standard, definitely an indentation gonioscopy is needed. ASOCT gives a very objective measurement. It is easily to explain the disease with the patient. UBM to rule out any secondary causes. Water drinking, dark room prone position can be done, but they are not very specific methods to diagnose angle closure. The treatment, laser peripheral iridotomy. Now, when should you do? Like, so after the ZAP trial, it is not necessary that we should do a peripheral iridotomy for all angle closure suspects. So definitely when it is an acute attack, and yes, the patient is a case of primary angle closure glaucoma, or even primary angle closure, you can definitely do iridotomy. Other findings or other conditions where you can do an iridotomy will be the fellow eye of a patient with angle closure glaucoma or angle closure, or with repeated episodes or symptoms, or if the patient cannot follow up, or if the patient understands the risk of progression and asks for a laser peripheral iridotomy. All these scenarios you can definitely go ahead with a peripheral iridotomy. Now, iridoplasty is one thing which we usually do in plateau iris syndrome. That means even after a patent iridotomy, if the angle closure mechanism persists, then you should always consider this diagnosis. The iridoplasty can be easily done using an argon laser. Anti-glaucoma medications and surgery, as we all know. Now, this is a simplified flowchart. When you have a patient with angle closure disease with visually significant cataract, when it is just PACS or PAC, you can just directly go ahead with phaco. Only when it is PACG, and again when it is early glaucoma, sometimes a phaco alone will be beneficial, but definitely when it is moderate or severe, a phaco trap should be considered. So the take-home message is history is very important, because angle closure disease can occur due to drug-induced and other mechanisms also. Gonioscopy is essential, which is the gold standard. Laser peripheral iridotomy is the first treatment of choice. Lens extraction does have a role. I won't say a clear lens extraction, but at least for early cataract or NS1, you can definitely consider lens extraction. Trap should be performed in moderate to advanced cases after proper counseling and taking care of the complications. Thank you. Thank you.
Next speaker to speak on MIGS gliding with KDB, Dr. Sanjay Mishra.
So a retina person is gliding with glaucoma.
So I was about to say that Madam has spoken my words. So good afternoon, everyone. I'm greeting from Army Hospital Research and Referral. I'm a retina surgeon who went on to become a keratorefractive. I'm doing a refractive surgeries also. And for last 6 months, I've started doing this MIGS. And I found it to be a very interesting surgery. So my topic is my experience with the Cahooks dual blade that is gliding with KDB for the MIGS. I don't have any financial interest. So this is one which is used for the MIGS surgeries. It bypasses the trabecular meshwork resistance, and it elevates and excises the trabecular meshwork to access the multiple collectors channel. The indications are it's used for mild to moderate glaucoma case trabeculoplasty, the patients who are non-compliant to treatment and who are experiencing drug reactions. It's minimally traumatic surgery. Modest yet sufficient efficacy is seen. It's a very good safety profile and very rapid recovery, and does not impact the quality of life. So this is how it looks like. I will be showing this, the video also. This is the Kahoot dual blade. There are 3 parts. You can see the tip, which is very sharp, then the ramp and the heel, and the side there are the 2 blades. So the tip is very sharp. It pierces the trabecular meshwork, and then you seat the heel, and you lift the trabecular meshwork, and the side blades, dual blades, they excise the trabecular meshwork. These are the benefits that it excises the strip to access the multiple collectors channel. It is implant free. At present is the only drug which is FDA approved for standalone MIGS surgery. It is very versatile, and this is for the excisional goniotomy. The preoperative consideration, who are the good patients? Anybody who is fit for cataract surgery, and you have explained the patient well, is a fit patient for this surgery. You have to have a preoperative look at the gonioscopy, and you can see the angle very clearly. Then you are going to have less trouble in doing this surgery. Any stage of glaucoma, in fact, I've done, usually it is prescribed that you do in an open angle. I've done in few closed angle also, where you're able to open up the angle with heel on. So where you don't attempt is that any patient with an active neovascular glaucoma, active uveitic glaucoma, where there is a raised episcleral venous pressure and the view of the angle is poor, and where you want a very, very tight control, that is the post-operative IOP of less than 10. There you don't attempt that. So you have to counsel the patient about the surgical procedure. I usually do all these cases under block, because you don't want any movement of the eye, and you are going to use air bubble in that. So you have to tell the patient that the vision is going to be blurred for probably a week or so, because there is also dispersal of the blood. So the vision is going to be blurred. It's very, very important to see the reflux of blood. You know, normally there is always when you see blood, you get scared. This is the only condition in surgery where you see blood and you feel very good about it, that your surgery has gone off well. If you don't get any bleed from the angles, that means you have to rethink that your surgery is done in a proper manner. You also take a history of patient being on anticoagulants. Preoperative preparations, like any other cataract surgery, that use antibiotic drop preoperatively. Pilocarpine, in case you're doing a standalone cases, I've done few standalone cases, including one gynecologist and a dermatologist. You have to tell about the patient about the preoperative. Tell the patient you have to tilt the head to an angle, and patient should not feel about it. You have to tell that. Otherwise, patient may say, "Why you are tilting my head?" When doing along with the cataract surgery, you have to inject pilocarpine to constrict the pupil and to have a better look at the angle. So the 3 techniques is, one is an outside in, one is inside out, and then is mark and meet, where you put a mark in the center and you come from both the side and meet in the center. So you see this. You have to, very important, focus in the infranasal quadrant, because that is where your collectors channel are in highest quantity there. So you, and mind you that, whatever the fear was there, it is hardly anything. There is a very little learning curve in this. You just do 1 or 2 cases and then you are good to go in this. And the surgical time is very, very less. In fact, if the last 2 days back only I did a standalone MIGS surgery, and the surgical time was less than 2 minutes. So this is very important. How do you, you have to place heel on the cornea, or you can put on the lens also, goniotomy lens. You put heel on the cornea, and you don't have to use any other viscoelastic. You have to inflate the AC with heel on only. And this is, you have to rest your hand on the forehead so that there is no movement of this thing. Do not use lens for directing the eye, because that is not correct. You will not get a good view of the angle. And then once you are there in around the angle, then zoom in. This is on the left side, this is the starting position of the microscope, which is normally what you use for cataract surgery or any other surgery. You have to move the microscope 30 to 40 degrees away from vertical, and then lift the eyepiece, because then it becomes otherwise not possible to operate. You have to lift the eyepiece, The newer, there is a microscope, C-Luma, which is being branded by Bosch. They say that this tilting of headpiece is not required. They are going to launch it next year. So you have to ensure 3 perpendicular planes, that is your microscope, iris and goniotomy device should be perpendicular. How optimal gonioscopic view should look like this? Like any other cataracts, one very important tip is that you have to go clear corneal in this. You cannot go around the limbus, because if you have little bleeding, then it's going to obscure your vision. You have to, like any other this thing, you have to tilt the tip and enter inside. Then once you release the trabecular meshwork, level is off. That means you become horizontal, and you have to put the heel first, make it flat, heel first, dip it perpendicular. The tip has to go perpendicular into the trabecular meshwork, and then make it flat. Then it goes horizontally in a smooth single. You cannot have a jerky movements. It's a smooth single motion, and it goes smoothly. You can do any of the technique, and then it has to go in one smooth motion. As I told you, the foot plate has to be seated well, and this is how you have to do it. As I told you earlier, reflex of blood is very important. You have to see that, and that is a good sign. And at the end of the surgery, you have to have a little higher pressure. That means you have to inflate the AC, and you have to maintain a pressure of around 25 to 30 millimeters of mercury, and you have to put air bubble in this so that you prevent further leakage of blood vessels. These are the things what you, if you have bubble, you again put extra OVD. If you are having corneal, you will have, initially you tend to put more pressure. You will have corneal stars, so apply less pressure, inflate the AC again, relax your instruments, and if you are not able to see this thing, you can stay in the trabecular meshwork also. And post-operative is very, very important. Apart from normal routine cataract, you have to put these patients on pilocarpine, 1 drop at night for a month. Very, very important. And as far as IOP, I stop all IOP lowering drugs on day 1 itself, and then titrate my patient as the patient goes on. And this is my experience that I've done around 62 MIG surgeries. After 4 months of follow-up, those patients who were on 4 and 5 drugs before the surgery were shifted to 2 drugs only in 26 cases, and in 1 or 2 drugs. In fact, few patients have gone off their drugs in almost 36 patients. Thank you. And this is what is the final this thing. Thank you so much.
Thank you. So we'll take the questions at the end. So we would request everybody to stay back. And now it's my privilege to introduce Dr. Manoj Chandra Mathur. He's been talking about post-cataract surgery, ocular hypertension and glaucoma. We all know Dr. Mathur as a very, very renowned glaucoma surgeon and a very conscientious, hard worker constantly. Thank you.
Thank you, Dr. Kirti. Like, I shall be speaking about the management of post-cataract surgery, ocular hypertension, or glaucoma. So, we know that fluctuations in IOP after cataract surgery are not uncommon. Yeah? Slides. Okay. But needs a detailed and meticulous examination to find out the cause, so that if timely addressed, can help us achieve better visual outcome. So, the pre-existing glaucoma patients are more prone for IOP spikes. Complicated cases with excessive tissue handling and prolonged surgical time can be one of the reasons for post-op ocular hypertension, and also intra-op complications like PCR, etc. So in these relative risk factors, there can be a problem. So this post-operative timing, the causes of IOP rise can be ranging from days to even years. What are the possibilities? Steroid responders, there may be an increase in intraocular pressure, release of iris pigment and inflammation, retained viscoelastic in the early postoperative period, there may be a problem, sulcus placement of single piece IOL, watertight wound closure, and retained intraocular debris. So, first, in the early post-op period, IOP can rise in a few hours after routine cataract surgery, generally returns to normal in 1 to 3 days. IOP less than 30 millimeters with non-glaucomatous optic disc and a deep AC should not be a problem. What are the causes? As we enumerated earlier, influence of viscoelastic substances, inflammation and hemorrhage, AC IOL and iris fixated IOLs, vitreous in AC, Pupillary block may be broken by a mydriatic or may need an iridotomy. Peripheral anterior synechiae or trabecular damage may be the cause. Flat AC should be corrected suitably, and distortion of the AC angle. A tight corneoscleral suture or edema of the deep corneal stroma. Postoperative ocular hypertension can be due to inflammation that is frank subclinical, seen only in the operated eye. But steroid induction, basically the point of differentiation between postoperative ocular hypertension because of subclinical inflammation is generally uniocular, whereas steroid induced generally it is binocular. How do you manage? Post-op use of oral acetazolamide and topical carbonic anhydrase inhibitors are useful. Generally, substituting brimonidine with dorzolamide, brinzolamide can be useful. This is my practical experience. Like brimonidine, it is known to more prone to precipitate allergy and some sort of increased inflammation compared to brinzolamide and dorsal carbonic anhydrase inhibitors. Steroid use also can be tapered and switched to a safer steroid like fluormetholone. I use fluormetholone or NSAIDs and stop prednisolone acetate in cases of steroid induction or generally post-operative ocular hypertension. Eyes with pre-existing glaucoma, there may be a further nerve damage with transient IOP elevation, and tight wound closure may be responsible in these cases. AION may occur in eyes with vulnerable ocular nerve head circulation. The management involves post-operative use of oral acetazolamide, and prostaglandin and PG analog should never be used for the first 3 to 4 weeks. Then comes the malignant or the ciliary block glaucoma. Shallowing or flattening of the central and peripheral anterior chamber caused due to misdirection of aqueous. It is aggravated by the use of miotics, and generally there is a relief with cycloplegics. The possibilities: there can be a peripheral pooling of the aqueous, there can be a ciliovitreal or a ciliolenticular block, there can be slackness of low lens zonules and anterior hyaloid obstruction. How do we manage malignant and ciliary block glaucoma? Cycloplegics may help by breaking the ciliary shock, by contracting the ciliary body which pulls the lens back, hyperosmotics to shrink the vitreous, and aqueous suppressants. Surgical by lasers, YAG laser posterior capsulotomy and disruption of anterior hyaloid may be useful, and prophylactic YAG laser iridotomy for the contralateral eye may be helpful. Medical treatment involves carbonic anhydrase inhibitors, beta blockers, alpha-2 agonists, and miotics can be effective too in this situation. Laser trabeculoplasty for cases without PAS, surgical intervention for cases with uncontrolled IOP or maximum medical therapy, trabeculectomy with antimetabolite, glaucoma-deranged device if superior conjunctiva is scarred, and transcleral CPC in patients with poor visual potential. So I'd like to conclude my talk by presenting you 3 scenarios. Case number 1, a 54-year-old female with a near total cupping, 0.9 cup in both the eyes, underwent a combined surgery. Preoperative intraocular pressure was 15 in the right eye and 11 in the left eye with 3 AGMs. Uneventful surgery with time of presentation 1 week post-op with IOP of 38 and in the right eye and 25 in the left eye. Patient was switched to fluormetholone with fast tapering, and then the second week IOP reduced to 20 and 15. A well-functioning bleb cause can be a steroid responder. Case number 2 underwent combined surgery, preoperative status poorly dilating pupils with NS3, uneventful surgery with use of pupil expanders, and then the time of presentation was 1 week post-operative, intraocular pressure was 28. The cause was detected to be retained cortical matter due to poorly dilating pupil. This was the cause. Case number 3, disc was within normal limits, time of presentation was 3 months. Delayed post-op ocular hypertension after cataract surgery, the pressures were raised up to 40, was put on conservative therapy, and then IOP at present was 12, came down to 12. The cause of it was the IOL in the sulcus. So these are the situations, and these are the things like how you possibilities and management for post-cataract surgery, ocular hypertension, and glaucoma. Thank you very much.
The next speaker is Dr. Meenakshi Dhar, and she will be speaking on pearls in phacotrabeclectomy.
If you have not loaded, we'll go to the next speaker. Huh? It's loaded? No? Okay.
Thank you to AIOS and thank you, Chairman. Coming to phacotrabeclectomy, we need to do it when glaucoma needs surgery and there is cataract, like in angle closure, open angle which is not controlled or visual field progression is there, or a cataract needing intervention and the patient also has glaucoma. Why do we do a phacotrab and not a trab alone? It's because it obviously is for the second surgery, which may compromise the filtering surgery, and the AC shallows further, especially if it's an angle closure. The chances of cataract to increase is almost threefold in the following time after trab, and a functioning trab may fail. And also patients prefer a single surgery, and also cost-benefit analysis ratio makes us feel that we should do for a phacotrab. The success lies not only in the surgical steps, but also in the preoperative and the postoperative assessment. In the preoperative, we should see whether there is any blepharitis, any scarring, whether there is any scleral thinning, how advanced is the glaucoma. And also, we should stop the prostaglandin analogs 3 weeks prior to the surgery. Try to, if possible, if it is the first eye which is being operated, try to shift them to oral acetylzolamide for a week or so, half TDS. Stop pilocarpine, and also start lotipred for the 2 weeks prior so that one has a less inflamed eye. Stop antiplatelets, of course, and if need be, give mannitol during the surgery. Surgical dilemmas are many, and hence we try A brittle suture can sometimes injure the superior rectus and superior oblique, so tonal stay suture is better. The fornix-based incision is better because it is easier to make, better visualization of the limbus. It is compatible with MMC usage, and the suturing is easier. And it is also done, the reason why limbal one is not good is because it may cause a ring of steel, although it depends on every surgeon's hands, and this may lead to an overhanging bleb because of the scarring which is there. The scleral flap may be triangular or rectangular, it depends on the surgeon's hand again. I am comfortable with both, but I now prefer to do a rectangular. And it is better to use the side port knife and then dissect it with a crescent blade. And it is better to use an atraumatic Pierce-Hoskins forceps. And the scleral flap should not go right up to the tip, and should at least leave 1 millimeter at the edge near the limbus, so that the flow of the aqueous once the surgery is done is posterior. Also, one should change the direction of the thing when it enters the cornea. And and if by chance you do have a amputation of the flap, you can always suture there. And coming to the rectangular one, I prefer to do this, a 4 mm and a 4 mm behind. Mitomycin C, it should be in a low dose for a longer time, say maybe 2 to 3 minutes. And when you are applying it, you do not touch the edge of the conjunctiva, so that there is the conjunctiva healing is not compromised. A good AC wash thoroughly through the conjunctival sac is a very a good thing to do, and change your instruments thereafter. And the sclerotomy punch, one should leave the same side, like if you have a 4 mm, leave 1.5 on each side, so that you have a good flow and it's done well. And the broad-based iridectomy prevents iris incarceration and ostium into the blockage, and one should ensure that it can be seen properly, and the base of the iridectomy should be wider than the sclerostomy opening. When we are doing the sutures, the reusable suture is very easy to do. One should not have the tip exposed, so one can follow this way to do it. And when we are tying the half knot on the releasable suture, it should be a slanting suture, so that it allows a drainage rather than be a watertight suture. Then coming to meticulous conjunctival suturing. If it is limbal, then you do it in 2 layers. When it is phonics based, you do it in such a manner that you put 2 mattress sutures on the side and bury the knot. And after that, we can check whether it is sealed well or not, and through the side port check that the pleb is forming and there is no leakage. You can also use the fluorescent strip to check that there is no leakage. And the Moorfield system of surgery, safe system surgery, should be followed when you are doing a phacotrap. Post-op care, 8 to 12 weeks of anti-inflammatory steroids as well as NSAID should be started after a few weeks. Cycloplegics is a must, atropine for 3 weeks or more if needed. Lubricants, assess the bleb as needed by AT, and bleb vascularity by SLE and by SASOCD can be judged. We want a bleb which is going as far as this bed of lilies and is shallow. And thank you for patient hearing.
The next speaker after Meenakshi's talk about pearls of phacotrabeculectomy, let us now move to the hypotony situations. To speak on that topic, none other than Dr. Kirti Singh. She is presently the treasurer of Delhi Ophthalmological Society and a prominent glaucoma expert in our country. Over to you, Kirti.
Thank you. So I'm supposed to cover hypotony in 7 minutes. It's a little impossible, so I'll be just talking about some aspects. So thank you, AIOS, for this. No financial interests. So trabeculectomy, unlike any other surgery, especially cataract, has a lot of twists and turns. It requires a lot of post-op care. It's just not one surgery, which Dr. Meenakshi has done so beautifully. It requires a post-op care to be done. And if you remember the old fables in our childhood, Red Riding Hood. Remember the Red Riding Hood? And she had the big bad wolf. And the big bad wolf in glaucoma surgery is not bleb failure, but the big bad wolf is the hypotony situations, which happen in almost 20% of the cases. So I'll be covering just 2 aspects of hypotony, an overfiltering bleb and a leaky bleb. Usually the IOP is normal to low and the AC is invariably shallow in these situations. The causes are early and late. Early causes are if you've used the mitomycin too excessively or more time, that can cause cerebral toxicity. The conjunctiva is leaky or your scleral flap is leaky. In that situation, the latter will have an overfiltering bleb. Late causes are conjunctival thinning and bleb sweating, trauma, second surgery, avascular thin conjunctiva, very common, and I'll be just briefly talking about a tendency for overfiltration. The predisposing factor are the scleral thickness, rigidity, and the extraocular muscle tone, and very important, duration of hypotony during surgery. During surgery, I always use a side port and do slow decompression, and I form the anterior chamber intraoperatively while operating, and at the end of surgery, I form the chamber either with air or with visco and leave a little bit of that so that the AC has to be formed, and myopic eyes. So the decision depends on the timing of the, is it early or late, whether it's a bleb leak or a bleb sweating, or conjunctival health is good or bad, visual acuity if there is hypotenuse maculopathy present or not, and of course other complications like cataract and corneal folds. So depending on these comorbidities in the ocular, in the eye, your decision would change. So the first one is a very simple thing. If you have an early leak, always try this very simple maneuver of a torpedo bandage. Try systemic astazolamide, always give a cycloplegic. I put atropine ointment, or sometimes we use something called as midrican, which is atropine plus adrenaline, and we put an ointment and we put this torpedo bandage on the patient's eye while the patient is looking down so that the bleb is covered. It usually resolves. If the leak doesn't resolve, you can do an amniotic membrane resurfacing, especially in situations where the conjunctiva is poor and the bleb dehiscence is there. This is a patient who was a rubber. He kept rubbing his eye post-op. We admit the patients for 2-3 days because our patients mostly come from far off. So this patient kept rubbing the eye and this conjunctiva just gave way, and we just did a resurfacing with amniotic membrane. One of the good things we found, a lifesaver, is autologous serum drops. Start making that of the patient's own blood because that helps in the healing, reduce the steroids, and in addition you have these special customized bandage contact lenses of 16 to 18 mm which we get made, and when they cover the bleb in totality, because otherwise the small bandage contact lens of 12 ml will never cover the conjunctival incision. Incidentally, we always use the Singh's frill incision, which was in between the fornix flap and the conjunctival incision techniques. If there's a gape, ooze, or a leak, you have to do a conjunctival advancement. Never do an advancement under tension. Give a relaxing incision in the fornix if possible or if required. And again, after I do the advancement, I use this large 16 mm BCL in situ over the conjunctival advancement flap. Autologous bloods is a very, as I said, autologous serum, and we also do, if it's an overfiltering bleb, you can just do a fresh blood drawn with the needle, and the needle is changed. Same patient, just draw the blood and just inject it, and sometimes it works because it induces fibrosis. Then the other problems are the bleb sweating and the overfiltration tendency or trauma, and this is again more common in myopic eyes with low scleral rigidity and younger patients. So one case we net of a patient of posterior scleritis and uveitis, they already had a weak sclera. She was a one-eyed patient, came to us with diabetes, hypertension. So trabeculectomy was done in 2013. She recovered good vision. Then again it failed over 10 years. 2022 we had a retrab, and after that she had a trauma with a door handle. She was bending down and the handle hit her, and she came to us with a visual deterioration and hypotenuse maculopathy. There was no leak, no overfiltration, but the sclera was thin. So we tried to cover with diflupred because that has a steroid responsiveness, because she came with a pressure of 4 millimeters and this hypotenuse maculopathy. But after 2 weeks of persistent hypotony, we knew that we could not do anything, so we did a patch graft. And after patch graft, this is the second trab. You can see the first trab had failed, second trab which had the trauma, and we put a patch graft, and this patient recovered and the macular hypertony recovered. So this is a technique of doing the patch graft, and we prefer to do a corneal patch graft and not a scleral. Reason being, cornea is easy to get. Second, the cornea is visible throughout and you can see the sclera through it. And third, cornea stays better. Scleral necrosis I have seen, scleral melting I have seen, but crossed fingers till today, no corneal melting has happened. So for tube shunts also we use the corneal patch graft, and so this is the corneal patch graft in position, and the conjunctival advancement has been done and the bleb has been resutured. Now this same patient had another sequel. She was little, and as said very rightly, that there's a sequel of any trab is cataract. So she required cataract surgery after 6 months, but the bleb held and the patch graft held, and it was pretty good. we have situations where you have avascular conjunctiva. In those situations with thin bleb with hypotony, more than 10 years of cataract surgery, this is a ticking time bomb. You know, this type of a bleb, you just can't leave it. So you just measure it and then take the corneal patch graft, size it, and I put it half thickness because the full cornea is thick and that will cause a Dellen formation here and resurfacing issues. So you size it and you cut it according to the size of the thinning, and we've sutured the corneal patch graft over it, and then again the same thing of the conjunctival advancement, and you suture that. The last situation, you may not have a cornea or a scleral patch graft. In those situations, do a Momini's repair. This is a short video, a very old video of mine, because we don't need to do that anymore. But this was in one which we used the patient's own sclera. You just create a hinge of the sclera and just invert it over the thinned area, and you suture that, and it works pretty well. And that was devised by Edward Momini, and we call it the Momini's repair, and that's pretty good too. And last but not, that is a tendency to overfiltration. This patient of overfiltering bleb we removed twice, and it just kept recurring because this patient had a tendency, so very rarely you have that. So thank you very much for having a patient hearing.
I invite the next speaker, Dr. Suresh Kumar, to deliver his topic on complications of glaucoma drainage devices.
Very good afternoon. At the outset, I am grateful to AIOS for the invitation and opportunity. Respected chairperson and dear friends, I will be speaking on complications of glaucoma implants. As you are all aware that glaucoma implants have become mainstay of surgical treatment of refractory and complicated glaucomas. However, these devices have their own issues, and they can have their own set of complications. These complications can be valve related, structure related, or surgery related. As Dr. Kirti Singh pointed out that trabeculectomy can have hypotony. Similarly, implants can have hypotony as well as hypertensive phase. Hypotony is IOP persistently below 6.5 millimeter mercury. It can be immediately postoperative, it can be transient or persistent, or it could be late onset, which is more likely to be persistent. And we are always worried about persistent hypotony after implant. It's even more serious than after trabeculectomy. And incidence of hypotony varies with type of implant, and we are more likely to see hypotony after non-valvular implants, that is Berwald or Adi implant. And causes of hypotony can be leakage from the surgical site, inadequate capsular formation to aqueous outflow. Then this could be non-device related like choroidal detachment, cyclitis, or perforation during the surgical steps, or it could be transient aqueous hyposecretion. And hypotony with associated choroidal effusion, mostly if it's small effusion, it will resolve automatically. After some time, large effusion, especially kissing choroids, may need choroidal drainage. And as the treatment of hypotony is difficult, it's better to prevent the hypotony. So either use a valvular implant or occlude the silicone tube by a stent or a ligature suture to prevent hypotony. And with hypotony, we are always worried about hypotonic maculopathy. You can have on fundus examination, you can see chorioretinal folds, retinal detachment, optic nerve head edema, cystoid macular edema, or there could be loss of central vision. So diagnosis is pretty obvious on your fundus 90-day evaluation, but sometimes OCT can help us in picking up the maculopathy and retinal edema. And management is mostly surgical, as Dr. Kirti pointed out. Remove the bleb and apply a scleral patch graft, cover with amniotic membrane and conjunctiva, and hypotony will be taken care of and maculopathy will resolve after some time. And management of hypotony, it's more serious as compared to trabeculectomy. And if hypotony is there with normal chamber, your endothelium is not threatened by the tube, then you can observe and if there is wound leakage, you repair the wound leakage. If it's choroidal effusion, then steroids and cycloplegics, and sometimes you need drainage. And if there is hypotony with flat chamber, you have to reform the chamber, and persistent hypotony, sometimes you have to apply ligature or you have to remove the implant also. However, the hypotony can have sinister underlying cause, like our patient had surgically induced scleral necrosis after rheumatoid he had in fact rheumatoid arthritis, so after implantation of AGV he had surgically induced scleral necrosis. This has been published in Journal of Glaucoma. So after 2 or 3 weeks, patient started showing area of scleral necrosis where implant had been put, and there was hypotony also. So unfortunately, even with immunosuppressive, azathioprine was given systemically, and 2 times scleral patch graft was put, but patient, we are not able to salvage the vision in this patient. So we have to be really careful. If patient is having underlying collagen vascular disease, we should be avoiding implants in these patients. And one of our patients, elderly female patient with pseudophakia, she had malignant glaucoma following implant, and the confusion was the pressure was on lower side. So malignant glaucoma can have IOP in the range of normal or even low levels. The chamber was flat, and UBM confirmed diagnosis in this patient, and patient did well after surgical vitrectomy and reformation of anterior chamber. This has been published in Indian Journal of Ophthalmology. And another aspect is hypertensive phase, which is seen due to bleb encapsulation, and patient hypertensive phase we are worried about because it can lead to further loss of vision, because patients are already having quite advanced glaucoma. And before we label a patient as hypertensive, we have to rule out outflow obstruction, which could be because of blood, fibrin, vitreous, lens material, or kinking. And laser works nicely if the tube is blocked by vitreous strands. Like this patient, you can clearly see the tube has been blocked by vitreous strands. And after ND-JAG lysis, the tube started working again, and IOP was controlled. And if we don't see anything obstructing the outflow, then it's hypertensive phase. It can occur as early as 3 to 6 weeks following surgery, or it can occur even late, 4 to 6 months after surgery. You can have typically congested eye with tense inflamed bleb, and IOP is normally more than 30-35 millimeter mercury. And preoperative risk factors can be very high preoperative intraocular pressure and high myopia. And your type of device, like it's more commonly seen with Ahmed glaucoma valve or valvular devices. Few of our patients with inflamed eye and tense bleb. And management is you increase the frequency of topical steroid. If it's a non-valvular implant, do the suture lysis, remove the ligature, do bleb needling to break fibrotic bands. If it's not improving, with conservative treatment, and sometimes if it is fibrotic capsule, you have to remove the capsule and put amniotic membrane, cover it with conjunctiva, then it starts working again. And structural complications, outflow obstruction has been discussed. Conjunctival erosion, implant explosion, tube migration can be seen in one patient also. Diplopia, if it's a large bleb, it can lead to mechanical obstruction and can cause diplopia. The erosion is seen in overall 2% of the patient, and all these factors, they make erosion more prone, more likely in these patients. And if it is small, limited, direct closure, if it is large, sometimes you have to put a patch graft, and recurrent erosion may require explantation of the implant. One of our patient is a child, she underwent AGV, and she had trauma, never informed the parents, and came with this picture. Tube has been extruded, and there was a patch of corneoscleral necrosis with iris prolapse. And then 3 millimeter corneoscleral patch graft was done, tube was cut, and child did well after the surgery. There could be surgery related complications like hyphema, cataract, corneal decompensation, endophthalmitis, vision loss, and surgical failure of your implant. And one of our patient had postoperative endophthalmitis. Unfortunately, we were not able to salvage the eye. So hypotony with normal chamber, observe, hypotony with shallow chamber, treat the cause, hypertensive phase, again conservative management in majority of patients. Sometimes you have to do blebber vision, and early recognition and prompt treatment is key for management of these patients. Thank you.
Thank you, Dr. Suresh, for that wonderful exposition of complications of glaucoma drainage devices. Because of paucity of time, we need to wind up the session.
Any
It was
questions,
a
quick questions,
very
one or two
fruitful,
for all the speakers, wonderfully covered topics.
it was a
So,
very fruitful.
any quick questions?
Any
Or most
question?
of you
Yeah.
want to go for lunch? Yeah. Mike, please.
Most cases, when you do a concurrent cataract surgery and you put, there's a diabetic macular edema, you put a concurrent Ozurdex implant. Usually this implant does not raise the pressure, but if suppose the patient is a steroid responder and the pressure is not coming down, you may have to do a vitrectomy and cut the implant, and then this takes care of that.
Yeah, so steroid-induced glaucoma is a big bane. Anyway, it's a necessary thing also. It's a vision saver, but it's a problem. Any other question or comment to the, if not, then I'll thank everybody for lovely lectures, and we have a group photo. Please come on the dais.